Let's talk a bit about the treatment of vitamin B12 deficiency. It's treated with injections of 1,000 micrograms a day, given for a week, followed by once a week for 4 weeks, followed by once a month until the stores are replenished. And then we have to give a maintenance dose of 1,000 micrograms injections every 3 months. Core therapy is indicated with oral folic acid, 5 milligrams a day. Folic acid deficiency is diagnosed. The gold standard test is a red cell folic acid test, not the serum folic acid test, but that's also done. The treatment is with 5 milligrams a day for about 4 weeks, and you can continue up to 4 months. Usually folic acid deficiency and B12 deficiency go hand in hand. Coming to hemolytic anemias, the normal red cell span is 90 to 120 days. A hemolytic anemia is diagnosed when there is increased indirect bilirubin, increased reticulocytes, increased LDH, which is typically LDH2, increased SGOT rather than the SGPT, and a decrease in haptoglobin. Note that the only thing that is decreased is haptoglobin. Increased reticulocytes can also be seen in other conditions, and mild reticulocytosis can be seen in active bleed, in myelophysis, in recovery phase of suppressed erythropoiesis. The workup for hemolysis includes a blood film, osmotic fragility test, a hemoglobin electrophoresis, a DCT and ICT, and urine and serum free hemoglobin and hemosiderin. Okay, so we have classified hemolytic anemias as intracorpuscular, also called intravascular, or extracorpuscular. Intravascular intracorpuscular hemolysis can be classified as RBC molecular defects, as in hemoglobinopathies and enzymopathies. Enzymopathies include G6PD deficiency, pyruvate kinase deficiencies, and hemoglobinopathies would include your HPS or sickle cell disease. RBC membrane defects would include hereditary spherocytosis, hereditary elliptocytosis, stomatocytosis, and an acquired one called paroxysmal nocturnal hemoglobinuria. We have environmental factors also, like the recluse spider venom, toxins like copper sulfate, autoimmune hemolytic anemia, malaria, and clostridial sepsis. The extracorpuscular ones include hypersplenism, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, and infections. Hemoglobinopathies are further classified, but I don't think this is necessary. This is a little further off. There are structural hemoglobinopathies, thalassemias, thalassemia hemoglobin variants, like hemoglobin E and hemoglobin constant spring and hemoglobin Lepore, persistent fetal hemoglobin, in which you have hemoglobin F throughout life, and the others, the acquired ones, that's methemoglobinemia and self-methemoglobinemia. Parvovirus B19 infection can trigger an aplastic crisis in patients with congenital hemolytic anemias. Sickle cell disease. There is a mutation in the beta globin gene that changes the 6th amino acid from glutamic acid to valine. The trait is asymptomatic and it's protective against falciparum. Now, there are lots of these congenital anemias that protect against falciparum, including thalassemia. RBCs get sickle when they get deoxygenated and they lose their pliability to go through the capillaries. So as a result, you get infarcts in the spleen, the marrow, the kidneys, the lungs, the liver, and even the brain, causing stroke. The most common manifestation would be a recurrent painful crisis. And the precipitants of a crisis include infection, hypoxia, exercise, anxiety, hypertonic dyes. So when the patient presents with an acute painful crisis, we have to look for these precipitants, which might not be very obvious, and we have to correct them. The complications include neovascularization of the retina, and that can cause blindness, autosplenectomy by the age of 3 years. Because of recurrent infarctions, the spleen doesn't work, it gets shrunken and doesn't work. That's autosplenectomy. That's typical of sickle cell disease. Susceptibility to capsulated organisms like pneumococcus and H. influenzae because your spleen is not working. Splenic sequestration crisis, the patient presents actually with shock because of a large amount of blood bypassing. Renal papillary necrosis because of acute renal failure. Aseptic necrosis of the femur or the humerus head causing acute limping or acute pain in the shoulder. Osteomyelitis. Dactylitis, which is also called hand-foot syndrome. Priapism or painful erection of the penis. Chronic leg ulcers and acute chest syndrome, which is due to pulmonary infarcts. The treatment of a crisis would be rigorous hydration. We look for the cause and we treat the cause, and we have to give them adequate pain suppressants like morphine and meperidine. We transfuse to keep a hematocrit of more than 30%. And if the oxygen saturation is dropping to less than 90%, like in the case of pulmonary infarct, we have to give them an exchange transfusion. The treatment of chronic disease, of chronic sickle cell disease, would be hydroxyurea. It's given to patients who have more than 3 crises in a year, or those with a repeated acute chest syndrome. Bone marrow transplant is curative, but it's safe only in children. Coming to hereditary spherocytosis, this is due to an RBC membrane defect, and usually ankyrin is what is deficient in 50% of cases. There are spherical RBCs. It's an autosomal dominant condition, so all the children would have would be split between 50% chance of getting it. The other inheritance is 20%. That is, your recessive inheritance will be 20%. It's detected in early infancy or in early adult life. And the patient would present with pigment gallstones in childhood. This is one of the causes for neonatal jaundice. Patient has a large spleen. There is extramedullary hemopoiesis, and the X-ray would show paravertebral masses. The tests to be done would include a blood film, which would show spherocytes typically. The MCV could be normal or mildly reduced. The MCHC is what is increased. And the osmotic fragility is deranged. When you go down the curve from 0.9 to 0.7%, that's when the RBC splits. Otherwise, the normal would be 0.4% when the RBCs start to lyse. So when the curve shifts to the right, we suspect hereditary spherocytosis. The treatment would be a splenectomy in moderate to severe patients. That's done after 4 years of age. Cholecystectomy should not be done without a splenectomy. Folic acid is given during any hemolysis attack for any of the hemolytic anemias at a dose of 1 milligram a day. If the anemia is not corrected after the splenectomy, what we do is we look for another diagnosis or for an accessory spleen that might have been left behind at the time of the splenectomy. G6PD deficiency. G6PD is needed to generate NADPH in the HMP shunt. This NADPH is what is needed to keep glutathione in the reduced state, which is GSH. And glutathione is what is needed to protect RBCs from oxidative stress. So G6PD deficiency, normal G6PD enzyme variant is a type B variant. And 20% of those from African descent have a type A+, but they have no problems. Clinically significant G6PD deficiency is in type A-. So it's an X-linked recessive disease. So all sons of the carrier mother get the disease, but the mother would have no symptoms at all. Usually, except if there are some hypotheses in which the mother can present with some amount of deficiency because of variable gene expression. Symptoms occur only on exposure to oxidative stress. And these oxidative stress factors could include sulfur drugs like sulfur methoxazole, nitrofurantoin, antimalarials like primaquine, pamaquine, and dapsone, naphthalene ingestion, metabolic acidosis, fava bean intake, and others like IV vitamin K, nalidixic acid, methylene blue, Now, G6PD deficiency can present in neonates as acute hemolysis, but it would be only on exposure to one of these factors. Otherwise, a G6PD deficient patient would be asymptomatic unless exposed to these oxidative stress factors. On exposure to oxidative stress, the patient has acute hemolysis. Hemoglobinuria, shock, and kidney shutdown would occur. And we have to have a high index of suspicion to diagnose a G6PD deficiency because there's no clear-cut diagnostic test other than the G6PD level, which is usually normal when you test it during the time of the crisis, because those cells that are showing G6PD deficiency could have hemolyzed. So we wait until the stress is actually over and then only do the G6PD assay. The treatment of this acute hemolysis would be IV saline at a high flow. And in adults, we give it up to 300 ml per hour of saline in order to maintain a good urine flow. For any hemolysis, we have to give them a good hydration with IV saline in order to make all the lysed hemoglobin and the hemoglobinuria to go out from the kidneys. And if we don't, what happens is the patient ends up with kidney failure and we have to dialyze them. We have to give an alkalining agent. We usually give soda bicarbonate along with the saline. And of course, if there's oliguria, there's no point pumping fluids. Patients going to go into overload. We have to do a hemodialysis. The test for G6PD, now we see Heinz bodies due to oxidation of hemoglobin on the very first day of the crisis, but this might not be there after that. There are bite cells. When the Heinz bodies are removed by the spleen, the RBCs are actually, the outer portion, the peripheral portion is actually bitten off, and it looks like a bite cell, which is half bitten off. So that's typical of this condition. Again, it's not seen in everybody. G6PD enzyme assays, I've already told you about. Newborn screening is done with a Guthrie test or a heel prick test. To immune hemolytic anemias, we have warm IgG antibodies, cold reactive, and the cold reactive itself is classified into IgM and IgG. But all the warm antibodies are IgG antibodies. You get them in CLL, non-Hodgkin's lymphoma, Hodgkin's lymphoma, SLE, drugs like alpha-methyl dopa, and even post-viral conditions. Like mycoplasma actually causes cold agglutinin. Yeah, cold agglutinin disease would be IgM antibodies, which is acute in mycoplasma infections with IMN, chronic in idiopathic and in lymphomas. The cold reactive IgG antibodies would include paroxysmal cold hemoglobinuria. The mild disease usually presents only with a positive DCT when you're doing when supposing a patient has to have blood transfusion or he has to give his blood for donation, then the patient has a positive DCT, and that's how they detect it. Moderate to severe cases, the patient will present with anemia and increased reticulocytosis and spherocytosis. In severe cases, there will be fulminant hemolysis and hemoglobinuria, and it can be rapidly fatal if we don't give them the appropriate treatment. Sorry about the spelling. DCT is positive in 98% of cases. Now, when do we do a DCT and when do we do an ICT? Does anybody know the difference? DCT is the diagnostic test for a hemolytic anemia. ICT is actually just to find out if there are antibodies present in the serum, like in a patient in maternal screens, when you test for Rh incompatibility, that's when you do an ICT, because you are testing the serum. You're not testing whether the antibodies are acting against the RBCs. Once that's already there, that's an autoimmune hemolytic anemia. But you want to test it before that happens. That's when you do an antibody screen. That's an ICT. It can be positive in Rh incompatibility for a pregnant woman. In Evans syndrome, there is immune destruction of platelets as well as RBCs. The treatment would be, in significant hemolysis, we give them prednisolone at a dose of 1 milligram per kg per day till the hemoglobin rises to normal. And then it's tapered to 20 milligrams a day, and then it's slowly tapered to a minimum dose in months. And the chronic treatment, we usually give alternate day steroids, 2.5 to 5 milligrams of steroids. If there's no response to steroids, we do a splenectomy. IV immunoglobulins is indicated if there's no response to steroids or a splenectomy. So the first option is steroids, second option is splenectomy, third option is IV immunoglobulins. Okay, paroxysmal cold hemoglobinuria. It was more frequent in tertiary syphilis, and so it's rarer nowadays than before. Now, most cases are due to viral infections or due to autoimmune disease. And what we see is Donat-Landsteiner antibodies. The patient presents with fever, chills, hemoglobinuria, and exposure to cold. It's usually self-limited. In chronic PCH, it's usually due to immune disease, and you have to give them steroids or cytotoxic drugs like azathioprine. Paroxysmal nocturnal hemoglobinuria. It's an acquired intracorpuscular defect at a stem cell level. And the features are hemolytic anemia. The patient presents with venous thrombosis. That is a typical feature, and that is due to complement activation. The patient has defective hemopiesis and pancytopenia in some. There is intermittent hemoglobinuria. CD55 and CD59 are absent, and that is a diagnostic test. It's done by flow cytometry. You can remember Ham's test and sucrose lysis tests are not reliable tests, but those are one of the tests for paroxysmal nocturnal hemoglobinuria. So the patient would present with a venous thrombosis and pancytopenia and intermittent hemoglobin. This is the triad. Okay, the treatment would be blood transfusion actually suppresses the marrow production of these bad cells. Prednisolone at a dose of 15 to 30 milligrams is indicated on alternate days. And we give thrombolysis in case of acute thrombosis, like in Budd-Chiari syndrome. And then we have to follow it up with heparin and then warfarin. Hemoglobin in various stages of development. At 6 weeks, the embryonic hemoglobin is called hemoglobin Fortlan, and you have hemoglobin Gower 1 and 2. At 11 weeks, you have fetal hemoglobin or hemoglobin F. That's alpha 2, gamma 2. At 38 weeks, that's when the adult hemoglobin or hemoglobin A, which is alpha 2, beta 2, is produced. So fetuses need alpha chain, but they don't need a beta globin chain for a normal gestation. Thalassemia is the commonest genetic disorder in the world. It's a disorder of alpha or beta globin synthesis. In beta thalassemia trait, the HbA2 level would be elevated. But this HbA2 level is actually suppressed in an iron deficiency. So if we have a doubt between the two, we can do an HbA2 level. And that would be increased in beta thal trait. It's seen mostly in people from the Mediterranean basin, Greece, Middle East, North and Central India, Southeast Asia, including South China. The heterozygous would usually be asymptomatic. You don't treat them. Sometimes you only see microcytosis and nothing else. Homozygous form would cause very severe congenital anemia, and they need lifelong transfusion support. Problems that are associated with thalassemia are usually due to the transfusions that they have. This is just an illustration. This is not what a hemoglobin looks like, but just to show you that it has two alpha chains and two globin chains. And in the middle of each, there would be heme, and the heme would have the ferrous component of iron inside it. So they have to be equally paired. You have to have alpha, alpha, beta, beta. Otherwise, there's a problem. So if there's a deletion or a reduction in the number of beta globins, and this is unequal, this causes beta thalassemia. If the alpha chains are unequal, it becomes an alpha thalassemia. So an unbalanced overproduction of alpha chains forms toxic inclusion bodies, and that kills the developing erythroblasts in the marrow. Compensatory erythroid hyperplasia would be there. So there would be chipmunk facies, frontal bossing, thinning of long bones, hepatosplenomegaly, leg ulcers, gallstones. There would be high output cardiac failure. One of the questions is, what is the cause of death? It's a high output cardiac failure. Death occurs usually in the first decade. And if they survive with blood transfusion, death occurs due to iron overload states. The diagnosis, you see the MCV would be low. Sometimes you see a normal MCV as well. Serum ferritin is normal or it's increased. And the blood smear shows target cells. which I've already shown you in the first lecture. There's mild hypochromic microcytic anemia. HB electrophoresis will detect the carrier states. DNA analysis, it's mainly used to detect the carriers and confirm the carriers. Alpha thalassemia, there's deletion of the alpha globin gene, which is located on chromosome, is that 16? I cannot see it. So 4 gene deletion, you'll get hemoglobin baths, not compatible with life. You have excess of gamma globulins, and this is hydrops fetalis. It causes hydrops fetalis. 3 gene deletion would cause something called HPH disease, in which there's excess of beta globins. And those patients present with moderate anemia, hepatosplenomegaly, jaundice, leg ulcers, and anemia. It's severe. 1 to 2 gene deletion need not have any abnormality at all, clinically significant. Beta thalassemia is due to point mutation of beta globin gene on chromosome 11. There are 2 types of thalassemia. You have minor thalassemia, which is asymptomatic or mild anemia, normal spleen or mildly enlarged spleen. But in the major form, you have all the problems, failure to thrive, severe anemia, all the other features that I've already mentioned. The treatment would be transfusion with packed cells, folic acid supplementation, and a low iron diet. Excess iron has to be treated with deferrioxamine. Myelodysplastic syndrome is a group of stem cell disorders. Ineffective hemophoresis is what happens. It's primarily a disease in the elderly. So if you have a multiple choice with the patient of 40 years, it can't be myelodysplastic syndrome. It's usually seen in the elderly people. It's usually asymptomatic, and you can find a very large spleen in myelodysplastic syndrome. Rarely, the patient presents with anemia, leukopenia, and thrombocytopenia. It's also called pre-leukemia, refractory anemia. It's a group of stem cell disorders where there is defective hemophoresis. Okay, so we've been through all this. Sometimes the patient can have a compounding B12 and folic acid deficiency as well. In about 5% of patients, they can present to acute myeloid leukemia. The treatment is supportive, and if the cell lines are down, we just transfuse them. There is no specific treatment except for bone marrow transplant, which usually is not done beyond the age of 70 years because the patient ends up having a 40% mortality rate because of the higher risk of infections. Hereditary hemochromatosis is an iron overload state. It's a most common serious single gene genetic disorder. It's a common condition. The total body iron concentration is 20 to 60 grams. There's excess iron everywhere. And what could happen is you could end up having cirrhosis. The pancreas could get damaged, causing bronze diabetes, bronze because the skin coloration becomes bronze in color. The heart, you have restrictive cardiomyopathy. You have pituitary gland involvement causing hypogonadism and impotence. The joints can be involved. There can be chondrocalcinosis. It's autosomal recessive. There are 2 common gene mutations, C282Y and H63D. And the clinical features, patients present with extreme lethargy. There could be, this could be the first presenting feature of a cirrhosis patient. So any patient with cirrhosis, we have to do a workup for hemochromatosis. There could be polyuria and polydipsia because central diabetes insipidus. Arthralgia and arthritis can happen. There can be erectile dysfunction, loss of libido, again because of pituitary gland involvement. There can be testicular involvement as well. So what we look for is the skin coloration. We look at the heart. We look at the rhythm of the heart on the ECG and an echocardiogram. We do a hepatomegaly screen of the liver. Liver biopsy is diagnostic in a patient with cirrhosis of the liver. So the diagnosis of hemochromatosis is with a serum transferrin saturation of more than 70%. And serum ferritin is, of course, very highly elevated. CT or an MRI can diagnose increased iron deposition in the liver. A liver biopsy, if the ferritin is very high, it's indicated. MRI may take over biopsy to evaluate the liver status. Genetic screening is done, and there's no need to screen before adulthood. Yeah, the treatment is mostly venisections until the serum iron stores become normal. And deferrioxamine can be used, but it's not as effective as a venesection. Patients given a normal diet, they're asked to avoid alcohol. The life expectancy is normal if treated before the cirrhosis or the diabetes develops. Okay, coming to multiple myeloma, it's a neoplastic proliferation of plasma cells producing a monoclonal immunoglobulin. So it's from a single clone. The most common translocation is a T1114Q13Q32 translocation. It's increased in those exposed to petroleum products and those working with leather and woodworkers. Malignant plasma cells secrete monoclonal antibody called the M protein. The most common presenting features, 70% of them have bone pain. This is due to lytic lesions, punched out lesions. Infections include pneumonias and pyelonephritis. Those are the commonest infections, and that's the second most common presenting feature. The first common presenting feature, that's the clinical manifestation. Patient comes to you is with bone pain. The second one they come to you is with infection. Sometimes just with recurrent pyelonephritis, we diagnose them as a myeloma. Anemia causing fatigue and renal failure. Neurological manifestations are muscle weakness, radiculopathy because of vertebral fracture causing a nerve compression, spinal cord compression, which is in 10 to 20% of patients, is a medical emergency. This can be treated if it's localized and a localized point of lesion that's causing a myeloma lesion, plasmacytoma that's compressing spinal cord. We can actually do radiotherapy for that as the treatment. Otherwise, we'll have to do a decompression surgery. Disorientation can be because of two reasons. One is the patient can present with hypercalcemia, and this is corrected very rapidly if you give them IV saline, just plain IV saline with large doses, plus or minus IV furosemide. And sometimes they need calcitonin, and of course, myeloma patients will require biphosphonates for a long period of time. The disorientation can also be because of hyperviscosity syndrome, where there's a high amount of paraproteins inside the blood. And this is treated with high amounts of IV fluid and plasmapheresis. If you look at a serum protein electrophoresis, and the first one is normal, that's what a normal one looks like. In polyclonal gammopathy, you find diffuse hemoglobin chain. In monoclonal gammopathy, you have a single spike, it's called a church steeple spike of the M band in serum protein electrophoresis. That is what is typical monoclonal gammopathy or myeloma. The triad of myeloma includes marrow plasmacytosis in more than 10%, lytic bone lesions, and a serum or a urine M component. In the absence of lytic bone lesions, you can also diagnose myeloma if there are progressive increase in M component or the presence of extramedullary mass lesions. The differential diagnosis, the most important one, is to see whether it's a non-malignant one, which is MGUS, or monoclonal gammopathy of unknown significance. This is in 10% of everybody more than the age of 75 years, so it's pretty common. Now you find less than 10% bone marrow plasma cells, while in myeloma we find marrow plasmacytosis more than 10%. You find less than 3 grams per deciliter of M components in the serum. There is no urine VJP, there is no anemia or renal failure, there's a normal blood calcium, there are no lytic bone lesions. Coming to multiple myeloma, the investigations that we do are a serum or urine electrophoresis and Ben-Jones protein in urine. Ben-Jones protein in urine is positive in only about 50% cases. Serum protein electrophoresis is what is the first choice. You also do a skeletal survey to see if it's punched out lesions in the skull and in the pelvis. You do a bone marrow aspirate and biopsy. The other tests that you would do are a calcium level and a complete blood count. And what we would expect to find is a normocytic anemia. In later disease, advanced disease, you can have a pancytopenia, especially when the platelet counts start declining. And some people die of bleed because of that. Plasma cell leukemia is when there is more than 2,000 per microliter of plasma cells circulating in blood. This happens in 2% of patients. Now, if they ask you the most sensitive test to diagnose it, serum protein electrophoresis may not be positive in everybody, but serum free light chains are very sensitive tests, most sensitive tests to do for multiple myeloma. Beta 2 microglobin is done to monitor the disease, the progress of the disease. The treatment is with dexamethasone and thalidomide until remission. It's about 4 months. And along with this treatment, you have to give them some amount of, the spelling of dexamethasone is with an E at the end of it. You have to give them prophylaxis against herpes zoster. So you have to give them acyclovir as well in order to prevent that. Maintenance therapy after 4 months would be lenalidomide, and the patient continues to have it for about 2 to 3 years, and then they are reassessed whether the M-band has completely disappeared or no. Okay, chemotherapy can be given. It was given in earlier days, now it's switched over to dexamethasone thalidomide. But in second-line treatment, if the patient is not responding, we give them chemotherapy, melphalan and cyclophosphamide or cyclophosphamide along with prednisolone. Bone marrow transplant is also a good option, but it's reserved for those patients who don't respond to dexamethasone thalidomide and if the patient is less than 70 years of age. Now, the treatment of hyperviscosity syndrome. Now, the hyperviscosity syndrome, the patient presents with tinnitus, blurring of vision, confusion, hypertension, high plasma M proteins. You do a plasmapheresis for these patients. The patient also would present with renal failure in these hyperviscosity syndromes. And the treatment of that also would be plasmapheresis, and that shows a better outcome than a peritoneal dialysis. Waldenstrom macroglobulinemia. The major manifestation is a hyperviscosity syndrome. It's a malignancy of about the spelling, it's LYMPHO, lymphoplasmacytoid cells that secretes IgM. And the IgM paraproteins are what are very elevated, causing the hyperviscosity syndrome. But unlike in myeloma, there is a lymphadenopathy along with hepatosplenomegaly. There are no lytic bone lesions, and the calcium level is also normal. Myelofibrosis is the fibrosis of the bone marrow, and there is marrow failure. It occurs in old age, people more than 65 years. There is pancytopenia, hepatosplenomegaly with a massive spleen. Peripheral smear shows teardrop cells. The marrow aspirate typically gives you a dry tap. The clinical features are severe fatigue, and the diagnosis is made by bone marrow aspiration. Transplant can be done in younger individuals. Right. In this chart, the main thing that I want you to note here is in myeloma, you have a normal alkaline phosphatase, despite lots of fractures everywhere. Usually when there are fractures anywhere, the alkaline phosphatase would tend to rise. But myeloma, the osteoblastic activity is 0 in those fractured components. So the alkaline phosphatase is normal. Now, in osteoporosis, every one of these is normal. Calcium is normal, phosphate is normal, alkaline phosphatase is normal. In malignancies, you would have a slightly elevated calcium and phosphate. Sometimes it goes very high, but the alkaline phosphatase also goes high. In hyperparathyroidism, the parathyroid levels are very high. Calcium is high and phosphate is low because the parathyroid does that, increases calcium absorption and releases the phosphate through the urine. In Paget's disease, you have calcium and phosphate, which are normal, and the alkaline phosphatase is very high, be in the tune of thousands. Chronic renal failure, you have a low calcium and a high phosphate with a slightly elevated alkaline phosphatase. Purple toe syndrome, this is actually not a bleeding manifestation. It is a side effect of warfarin, and it's seen within 4 to 5 days of starting the therapy. It can also be seen with heparin. They have painful toes, which are purple in color, but there is no bleed. we usually stop the drugs and substitute with another. Elderly people and those with atherosclerosis are more prone. The contraindications to warfarin, this is very important. Known large variceal, esophageal varices, significant thrombocytopenia, within 72 hours of major surgery with risk of severe bleeding, previously documented hypersensitivity, acute clinically significant bleed, and decompensated liver disease or deranged clotting screen at the baseline, and pregnancy and within 48 hours postpartum because it's teratogenic. But it can be given during breastfeeding up to 12 milligrams a day. Okay, now this, they might ask you, I'm not very sure, but in patients with a low thrombotic risk, we have to stop warfarin for 5 days prior to the procedure. And we have to, in a patient with a high thrombotic risk, we substitute heparin within 2 days before the surgery. We have to give them unfractionated heparin IV or low molecular weight heparin IV within 2 to 3 days before the surgery. And we recompense the warfarin to the previous normal dose after the risk is low. But in a low thrombotic risk patient, we don't usually need to give them that unfractionated heparin before. And we check the INR, and if it's not within the normal range, we can give them even potassium, IV vitamin K, 1 to 2 milligrams before the surgery, the night before the surgery. The medications which increase the risk of bleeding, if you give them along with warfarin, anticoagulation, these anticoagulants, NSAIDs, antithrombotic agents, and medicines like fish oil, because omega-3 fatty acids, they actually increase the risk of bleeding. Garlic, ginger, ginkgo, and these papaya and cranberry. Coming to hemostasis, the important thing we need to know in this pathway, if we know this pathway, then we'll know which test. The only thing they'll ask you is which test is done to diagnose which disease. And if you realize, the intrinsic pathway is a long one, the one that starts with 12 to 12A, 11 to 11A, 9 to 9A. And that's the only thing that's extra. After that, you have 10 to 10A, then that converts prothrombin, which is factor 2 to 2A, and that converts 1 to 1A. And then, of course, you have the cross-linked fibrin clot. But in the extrinsic pathway, when there's a tissue injury, there's 7 which is activated, factor 7 to 7A. Then that again comes to 10 to 10A, it activates 10 to 10A. So 10 onward, you have a common pathway. So anything below this that is deficient, that's factor 10, factor 2, factor 1, and even factor 5. Factor 5 is what is necessary to activate 2 to 2A. If any of these are deficient, you will see both the PT and the PTT increased. Now, the way I remember it is, this is a small pathway that is tissue injury, the extrinsic pathway, that's trauma causing 7 to 7A activation. The small pathway, we diagnose it by the small one, which is PT. And the long pathway, which is the intrinsic pathway, we diagnose it by the long name, which is PTT. So factor 8 and factor 9, if you see, are in the intrinsic pathway. Factor 8 is necessary for activation of 10 to 10A, this side. So hemophilia, both A and B, is diagnosed only with the prolonged PTT. But your liver disease, you'll have both PT and PTT deranged. You can see why, because all these factors are made by the liver. Now, yeah. So can anybody tell me, if you have factor 7 deficient, which is the abnormal test that you will see in factor 7 deficiency?
PT.
PT, right. So the PT is what is diagnosed with the extrinsic pathway, and PTT for the intrinsic pathway. You know that, you should be able to answer most of the questions. Okay, so the extrinsic pathway, there's some mnemonic that has been given, WEP for extrinsic pathway, that measures 1, 2, 5, 7, and 10. It's measured by PT and it's prolonged by warfarin use. But the intrinsic pathway is, the mnemonic is HIP, that's 2, 5, 8, 9, 10, 11, and 12. It's measured by the PTT. It's prolonged by heparin and by hemophilia.